we have treated maybe more than 70 cases in the state over the last 2 years or so. 70 cases of amoebic meningoencephalitis over 2 years in a small geographical region means that there is a lot for us to learn, and a lot of things are yet to be learned. So, based on our experience, the state guidelines which were released last year had to be revised this year. Okay, so I'll go to the topic proper. Share my slides. Basically, I will share over the next 30 minutes or so the current understanding, our understanding about amoebic meningoencephalitis, and based on our experience. So basically, it is not going to be much of a theory or anything like that. So the current knowledge that we share with regard to the epidemiology as well as the treatment of amoebic meningoencephalitis in the state, I will take you through. Basically, I started with this slide because Kerala is a gold-zone country because of the mountainous terrain as well as the.
Sorry to interrupt, that is not full screen yet.
ഇപ്പൊ സെക്കൻഡ് സ്ലൈഡ് ആയോ?
സെക്കൻഡ് സ്ലൈഡ് ആയി, പക്ഷേ സ്ലൈഡ് ഷോ ആയില്ല.
സ്ലൈഡ് ഷോ ആയില്ല അല്ലേ? ഞാൻ ഒന്നും കൂടെ ഷെയർ ചെയ്യാം. ഇപ്പം സെക്കൻഡ് സ്ലൈഡ് ആയോ?
സ്ലൈഡ് ഷോ മോഡിലോട്ട് വരുന്നില്ല. അരവിന്ദ് അത് പ്രസ് ചെയ്യുന്നേ കണ്ടു, പക്ഷെ അത് സ്ലൈഡ് ഷോ മോഡ് ആവുന്നില്ല.
സ്ലൈഡ് ഷോ പ്രസ് ചെയ്തെങ്കിലും വന്നില്ല. ഓക്കെ,
അല്ലെങ്കിൽ ഇങ്ങനെ പോട്ടെ.
ഫസ്റ്റ്
സ്ലൈഡ് ആയിപ്പോ
ഇപ്പൊ സെക്കൻഡ് സ്ലൈഡ് അല്ല അല്ലേ? ഫസ്റ്റ് സ്ലൈഡ് ആണ്. ഓക്കെ, ഇപ്പൊ സെക്കൻഡ് സ്ലൈഡ് ആയോ?
അതെ, ആയി.
ഓക്കെ, ശരി. So basically, we refer to Kerala as gold-zone country because of the mountainous terrain as well as the abundance of backwaters, ponds, etc. So now this, the abundance of these water bodies have become a problem to us. For example, all of you know that under a One Health platform, almost all the wells in the state are going to be chlorinated today and tomorrow. So the total number of wells as far as the 2011 census, so the groundwater census is concerned, is around 65 lakh open wells are there in the state. And then there was another census with regard to the water bodies in India in 2023. So around 56,000 ponds are there in the state. So 56,000 ponds and around 65 lakh the wells means that there are a lot of water bodies, and we know that all these water bodies are inhabited by all sorts of free living amoeba. So just a brief introduction about what we know about this from literature. So whenever we talk about amoebic meningoencephalitis, we refer to it as primary amoebic meningoencephalitis, or the PAM, which is usually caused by the free-living amoeba Naegleria fowleri, and this is the one which is associated with around 98 to 99% the mortality. So whenever we talk about amoebic meningoencephalitis, it is assumed that we are talking about PAM, but that need not be the case. And we always say that why we had an increase in case means over the last 2 to 3 years, we attribute it to this global warming, because when the temperature in the water bodies are going up, so this Naegleria fowleri is a thermophilic free living amoeba. So when the temperature increases from 30, means the chance of our water bodies having more of Naegleria is there, and also when the temperatures go up, the Naegleria feed on cyanobacteria. The availability of cyanobacteria also goes up. And during summer, it is the practice of children to jump into the water bodies, and suppose the Naegleria is there in the bottom of the pool, and if they actually tamper with the mud, etc., Naegleria will come to the top of the water body. And this Naegleria can survive temperatures up to 45 degrees Celsius, and is usually found in the soil, freshwater ponds, lakes, rivers, streams, hot springs. And we have isolated Naegleria from even the well, their water tanks and all those things. We have isolated in our own state. But then the most important thing is that all these things are attributable only to Naegleria. For example, Naegleria cannot survive in the saline environment. It is not there in sea, and in say cold environment, Naegleria can't survive. But this is not applicable to other free living amoeba. All the cases in the state, for example, we had around 80 cases over the last 2 years. So Naegleria contributes to only around 10 10 cases. The rest of the cases are acanthamoeba or say vermamoeba, and a lot of cases we don't know the etiology. So it is a FLA, free living amoeba PCR positivity. The problem with this acanthamoeba is that it is ubiquitous, it's present everywhere. It is not a thermophilic sort of thing. It can be there, means in almost all water bodies. There is no problem with pH for its survival for acanthamoeba. It can survive in very cold environments, saline water in the sea, etc. Acanthamoeba can survive. A lot of cases which are being reported this year happens to be due to acanthamoeba. So risk factors and all, all the conventional risk factors. So apart from the conventional risk factors, one thing that we need to be very, very careful about is the use of the water. So non-boiled water for nasal irrigation. So this is also reported as a risk factor, especially from Pakistan and all. We have a lot of cases where, following the ritual ablution, so they had the cases of Neigleria meningoencephalitis. In our state also, last year and this year, we had certain cases which were directly linked with the installation of the water into the nostrils. So usually we know that this will present as meningitis or meningoencephalitis, and the mortality that we usually say, that is 97 to 99% fatality, is with regard to the primary amoebic meningoencephalitis due to Naegleria fowleri. So basically, this is something we all know. The CNS syndromes due to free-living amoeba is divided into two. That is a primary amoebic meningoencephalitis due to Naegleria fowleri, with a mortality of around say 98 to 99%, and granulomatous amoebic encephalitis due to acanthamoeba species, Valamuthia, Sapenia, Vermamoeba, or Paravalcampia francinae. There are other etiologies like Venella, etc. also. So these are the, out of 400 free-living amoeba, these are the 6 free-living amoeba which are supposed to be pathogenic to humans, supposed to be pathogenic. So others may also be pathogenic, but as of now, we don't have any PCR technology to diagnose them. So these are the 6 ones that we should be very, very careful about. So primary amoebic meningoencephalitis is due to Naegleria, and granulomatous ones are due to the other ones. In Kerala, over the last 2 years, the ones that have been reported or diagnosed are Naegleria, acanthamoeba, and Vermamoeba vermiformis. That is very, very interesting because Vermamoeba used to be referred to as Hartnella in the past. So in 2023, one case of Vermamoeba encephalitis was diagnosed in Alleppey. Prior to that, only one case had been described in literature as causing encephalitis in humans. So it is FLA, but only one case was described in humans. But last year, a lot of cases of Vermamoeba vermiformis PCR positive. The amoebic meningoencephalitis was reported from Kerala, and some of them did die as well. So this is an emerging pathogen in our state. So Sapenia, Valamuthia, and Paravalcampia francinae. So no case have been reported from our state. So basically, we are focusing on Naegleria, acanthamoeba, and Vermamoeba. And the basic difference is that in Naegleria, the incubation period is around say 7 days, and usually you get a history like bathing in ponds or something like that. And within 7 days of that event or exposure to Naegleria-ridden water, the person is developing symptoms of meningoencephalitis. So that is a primary amoebic meningoencephalitis, and the patient, if not identified and treated at the right time, so usually dies within 7 days. So that is how catastrophic the cytokine storm will happen in the brain. And Naegleria fowleri, because of the sucker sort of thing and all, it can dissolve the brain tissue using enzymes like hydrolase, phosphocolinase, and all those stuff, along with the cytokine storm, there is immune response, which is a type 1 immune response in case of Naegleria fowleri. Whereas in other causes of amoebic encephalitis, which are often referred to as granulomatous one due to acanthamoeba, we get time. And suppose if you ask me what is the incubation period of acanthamoeba, the literature says that the incubation period is actually not known. It could be days, it could be weeks, it could be months. So we don't know the incubation period of acanthamoeba meningoencephalitis and how long it will take after this acanthamoeba gets into the brain or CS space to develop the symptoms. And also we don't know. It is going to be a subacute process or say a chronic process. It can also present as acute meningitis, but the primary amoebic meningoencephalitis is always an acute meningoencephalitis. The same we cannot say about acanthamoeba or Valamuthia. And if you are diagnosing it early, they may not manifest with the granuloma. The granuloma takes time. So type 4 hypersensitivity is acting in this granulomatous amoebic encephalitis, whereas it is more like an anaphylactic sort of thing happening in the brain, or type 1 in primary amoebic meningoencephalitis due to Naegleria. So till 2023, so whatever cases of amoebic or primary amoebic meningoencephalitis were diagnosed in our state, all of them had died. So we had seen cases, but we could not do anything, and some of the cases were diagnosed post-mortem. And if you go through the literature with regard to primary amoebic meningoencephalitis, you can see that majority of the cases were diagnosed post-mortem. So that is how fatal this PAM can be. And out of the 450 or so cases reported in literature, only around 11 have survived. So we know that CDC says that a 28-day course of the drug cocktail, the 5 drugs have to be given together, but only 11 have survived. We are not talking about the Kerala data. Apart from Kerala, only 11 have survived in across the world. But if you are looking at Naegleria data from our state, out of around 8 cases of PCR confirmed Naegleria infections in the state, only one have died. Okay, and that was a means co-infection with Naegleria and Vermamoeba. So if you want to save cases of Naegleria, early diagnosis is very very important. So any case with any suspected contact with water, immediately you need to do the wet mount and ask the alert the microbiologist to look for trophocytes, because that is very very important. Only a trained microbiologist with enough and more patients will be able to diagnose these motile trophocytes, and now the PS lab can do the PCR as well. Okay, so if you are able to diagnose this Naegleria, this primary amoebic meningitis at the earliest, and with the right timely initiation of this 5-drug cocktail, the Kerala has showed that we can save these patients, especially in children. Since there is no space for the brain to expand, timely initiation of immunomodulators along with this anti-amoeba cocktail drugs along with neurocritical care is the only way in which we will be able to save these children. Whereas in case of acanthamoeba and all, we will get more time. So this is with regard to the Kerala data. This in 2016, 2015 also we had a case of Naegleria which died. 16 Naegleria died. 19, 20, 22, 23. So all the cases till 2023, they were due to Naegleria or acanthamoeba or so Naegleria or Vermamoeba, but then all of them had died. So this is our the concept about how a primary amoebic meningoencephalitis is supposed to behave. And also with regard to this acanthamoeba meningoencephalitis, you are going through literature, the mortality is around 60 to 90% based on the underlying immunocompromise. So usually this amoebic meningoencephalitis due to acanthamoeba is occurring in the immunocompromised population, and that is not what we are seeing here. The immunocompromised will get it, but immunocompetent also are getting diagnosed with acanthamoeba meningitis or meningoencephalitis. Then till the end of July, we had around 8 cases of that is last year July. So we had around 8 cases of amoebic meningoencephalitis in the state, of which 4 had died. So all these cases were clustering in, you can see Malappuram, Thrissur, Kannur, Kozhikode, Palakkad, and majority were being diagnosed from this Kozhikode Medical College, and they were due to Naegleria, Vermamoeba, acanthamoeba. So at that time, the mortality was around 50%, and that is actually okay. Initially, all the cases had died, but then there are a lot of awareness campaigns going on in Calicut region, which actually helped in early diagnosis of certain the pediatric patients with this thing, primary amoebic meningoencephalitis, and they could save the patients. And at that time, miltefosine was not available. All those things, the state intervened and then made this miltefosine available. So till July 2024, so this was the scenario in the state. We had only sporadic case. What sporadic case means, usually there is no clustering in case of amoebic meningoencephalitis. Suppose one person is developing Naegleria from a pond. If 26 lakh people are taking bath from the same pond, only one is going to develop it. So that is actually saying that a clustering is unlikely to occur from a common water source. Okay, this has happened with regard to the ritual ablution and all, but otherwise, if 26 lakh people are, this is a modeling, this is what CDC says, 26 lakh people are taking bath in a pond with Naegleria, only one will develop. So that has been the general thing happening in the state. We have had clustering only in Trivandrum. In all other setting, there was no clustering. So it was all sporadic cases. And average age, it was a pediatric thing. It's 8 years, 3 to 14 years used to be the range. And 3 were female, 5 male. All of them had features of meningoencephalitis. One had seizures with holomyelitis and quadriparesis. This is very, very important. So at that time, we thought that this is sort of an outlier. There is one child. Usually, it is a meningoencephalitis or meningitis. than or encephalitis per se. One child last year had holomyelitis with coronary paresis, and we were really confused whether it is really due to amoeba or due to something else. But this year we had three other patients almost mimicking GBS like presentation, then LETM sort of presentation, that is longitudinally extending transverse myelitis. So basically, the spinal cord involvement can also occur with amoebic meningoencephalitis is something that we need to know. Out of the 8 cases, as we have already discussed, 50% died. And a history of bathing in a stream, pool, ponds, etc., could be elicited in 7 cases, and history of ritual ablution was present in 1 case. This is till July 2024, and this is important. So, average duration between onset and death was 14 days. Average duration between onset and admission is 4.5 days among those who died, and 3 days among those who recovered. So basically, in case of a primary amoebic meningoencephalitis, if you want to save the child or the patient, you need to diagnose at the earliest, and you need to start the right treatment at the earliest. And North Kerala, especially Calicut area, they were very successful in doing so, and that is how they were able to bring down the mortality. So last July, that period itself, maybe there are a lot of meetings at the minister level as well as the CM level, and following which the state guidelines for treatment of amoebic meningoencephalitis were released, and where we stipulate the treatment of PAM, this for primary amoebic meningoencephalitis, with a combination of amphotericin deoxycholide. Liposomal amphotericin is inferior to the conventional one for the treatment of Naegleria meningoencephalitis. Azithromycin 10 milligram per kilogram. Miltefosine was made available. Fluconazole and rifampicin. So all these 5 drugs are to be given together for say 28 days, but then later we had to customize it. And the treatment for this Acarnamoeba, Balamuthia, Vermamibia, Sapini, etc., slightly different from the treatment of Naegleria. But at that time, we never had rapid access to the molecular methods. So what we used to do is the microbiologists used to report this the trophocytes in wet mode, and we used to assume it is a primary amoebic meningoencephalitis, and used to hit hard with this cocktail along with dexamethasone, which was given for initial 4 to 6 days. And then we used to send it to PGI Chandigarh or say AV Institute Pondicherry for the PCR confirmation. It used to take time, 2 to 3 weeks. And then once the species is identified as Acarnamoeba or as Naegleria, we used to customize the treatment. So you know that from this year onwards, our PH lab is able to diagnose 5 of this. That is, apart from Sapinia, so they can diagnose Naegleria, Acarnamoeba, Balamuthia, Vermamibia, and this thing. So Naegleria, Acarnamoeba, and Paravalcampia francina. So 5 of them can be identified by PH lab, and that is helping Trivandrum Medical College like anything, because within 1 to 2 days you are getting to know the PCR, so that if it is Acarnamoeba, we are cutting on the toxic drugs like amphotericin deoxycholate, and we are going with other drugs. So for example, cotrimoxazole has excellent activity against Acarnamoeba, so we put in this cotrimoxazole instead of rifampicin like that. So this Naegleria, it's a all-out treatment with this cocktail. But if it is some other species like say Vermamibia or Acarnamoeba, so we look at the intracranial pressure or optic nerve sheath diameter and customize treatment accordingly, so that the risk versus benefit is optimized. And then till then, the question was, all these cases were being reported from this thing, North Kerala, it is in and around Calicut, and we never had any cases in South Kerala. So what is happening in North Kerala? So at that time, the explanation we gave were, since North Kerala, Malappuram, Calicut, etc., there is always the threat of Nipah hovering in the air. So they need to find the diagnosis for each and every case of encephalitis. So they will keep on checking for all cases of meningoencephalitis. They will check for Nipah if it is negative, like that. And that is how they are aggressively looking for an etiology in encephalitis, and that is how this wet mount got done, etc. So that was the explanation we gave. And then this happened in Trivandrum. We had a 25-year-old with history of a traumatic brain injury 4 years back. He presented with classical features of meningoencephalitis of 5 days duration, and he had a history of recent bathing in a pond. But unfortunately, even though the doctor from the local hospital, that is the general hospital itself, diagnosed, I think Nayyatikara Taluk Hospital suspected amoebic meningoencephalitis and referred to Trivandrum Medical College. Since the surgery was done in some other private hospital in Koranjeri, they went there, and so there was a delay in coming to our casualty, and he reached, I think, after 4 to 5 days. and he had an arrest in casualty. Okay, and then we had to resuscitate, and he died after 48 hours. But since there was a history of bathing in pond, we suspected amoebic meningoencephalitis. CSF showed motile trophocytes, and even though we initiated the treatment, he died within 48 hours. So this was our first case. And you can see the CSF study just more like a pyogenic meningitis. The sugar, a borderline hypoglycemia is there, a polymorph dominant pleocytosis is there, the culture and all these things were negative, and CSF, the trophocytes were present. So then, so we took it as a one-off event. But 1 week later, we had the next case. He was the cousin of the index patient. He also present with the features of fever, headache, and neck pain. So neck pain was classical. So it's sort of a radiating pain, and he presented with like this. And then we got a call from the resident saying that the cousin has come with almost the same symptoms. And according to our knowledge, clustering is not likely to occur from. So they had the bath from the same temple pond. So same pond, not temple pond, same pond, I think. And then we said that the clustering is not possible. Means after taking bath in a pond, but still the CSF was there and showed motile trophocytes. And then two other friends, were simultaneously being treated in other wards. They had the similar symptoms, and the CSF showed motile trophocytes, and all of them turned out to be Amoeba by PCR. Then we realized why something fishy is actually going on, because when we are looking at the North Kerala experience, all those patients were children, right? So, and there was all these cases are sporadic. And this is an young adult population, and there appears to be a clustering, and all of them had taken bath from that Kavankulam pond. But then there was something fishy going on, and then we got a history saying that no, some of them, means out of the 7, I think 5 of them, used to vape. Vape means they used to take water from the temple pond and put some stimulants, and they used to inhale that. And then we identified the other people also who used to do this from the same area. But the thing was, all of them did take the bath from that pond as well. So by snowball sampling means you identify people who had the same high risk behavior, that is vaping, and we did the CSF study, and we were able to pick up this meningoencephalitis at a very early stage, and we initiated treatment. We could save all the other 7. At the same time, so we became aware of, our microbiology department got alerted to the presence of amoebic meningoencephalitis in South Kerala as well. So we started, looking for amoeba in almost all cases of meningoencephalitis, and at the same time, we were able to identify another lady who had a bath in a stream and had Amoebic meningoencephalitis. Another person whose exposure is probably from an overhead tank. So it was the Kerala picture till then. So you can see that after that there was a clustering sort of thing. So after that, we sort of changed our testing methodology, and we started in almost all cases of meningoencephalitis. We aggressively used to send for this wet mount examination, but still for the PCR confirmation, we had to wait for say 1 to 1.5 months sort of thing. And this is the 2024 story. You can see that till 2023, almost all the patients in Kerala had died. In 2024, we had 39 cases, and the number of deaths were 9, and that is around 23% mortality. So you know that for Naegleria, the mortality globally is around 98 to 99%. For Amoeba in immunocompromised, the mortality is around 60 to 90%. So usually this Amoeba is usually not diagnosed in immunocompetent. Majority of our patients were immunocompetent, and probably that is the reason why the mortality was slightly less. But still, 23% mortality for amoebic meningoencephalitis is unheard of, and this was made possible because of streamlined guidelines for treatment and early aggressive detection of cases. Because even in Naegleria, only out of 8, only 1 had died. So this is the 2025 story. So we started pretty slowly. So you can see that in February we had 6 cases, March 3 cases, and majority of the cases were being reported from Calicut as well as from Trivandrum area. And August, it is not 18. I think it is around 22 cases now. So this year also we had around 40 cases. Last year around 39. This year 40. So maybe around 80 cases in 2 years' time. So that is what is happening now. Okay, you can see the distribution. The Malappuram, this year Malappuram had 14 cases, Kozhikode, Trivandrum, Kollam. So the patients who are being diagnosed in Trivandrum, all of them are not really from Trivandrum district, they are from Kollam districts, and also some patients were from this Kanyakumari district as well. So almost apart from say Idiki or Kottayam, so all other districts in Kerala have reported amoebic meningoencephalitis. Okay. Now, when we are looking at the probable water source, so this is not from our data per se. So this is from the CDC data. This is there in our state guidelines as well. So this is with regard to Naegleria. Okay, over the last 5 years. So this is from an article. It shows that you can get exposed to Naegleria in multiple ways. It need not be through just by swimming in ponds or bathing. It could be do water sports, nasal irrigation, very very important, or just a splash onto the nose. So during water festivals, swimming pools which are not properly chlorinated from tap water, even from tap water, they have isolated Naegleria. So the geothermal water tank. So so who are yeah, you just imagine, all our homes will be having water tanks and how frequently we are cleaning these water tanks, etc. So this shows that probably the chance of you getting exposed to this amoeba is real. Okay, so just by taking a bath itself, there is a possibility that you might get exposed to amoeba, but whether you will develop amoebic meningoencephalitis or not is another thing. And probably previously we used to think that only those with, say, problems with the cribriform plate will develop this amoebic meningoencephalitis. And Naegleria, the route of entry is actually through the nose, and after the cribriform plate, it will get into the olfactory bulb, then olfactory nerve, and the orbitofrontal cortex. Acanthamiba, the source of entry can be the nose, but there are other sources as well. It can go to the lungs. You can inhale it to the lungs, and then through hematogenous spread, you can have a disseminated acanthamoeba infection, including meningoencephalitis. Balamuthia and acanthamoeba can get into the body through wounds as well. So if you are having a meningoencephalitis and you are seeing a trophocyte, and if there is a wound, you need to think about acanthamoeba as well as Balamuthia. So this clearly shows that usually when we think about this amoebic meningoencephalitis, you think about asking for exposure to pond water, etc., and that need not be the case. നമ്മളെ ഈ കുട്ടികളെ ഇങ്ങനെ ഗാർഡൻ ഹോസ് പോലും പ്രോപ്പർലി അവർ കൊടുക്കരുതെന്നാണ് പറയുന്നത്, ബിക്കോസ് the water sprinkle can get into your nose, and probably that might contain Naegleria or acanthamoeba like that. Now, coming to from 2024, what lessons we have learned? This part is there in the state guidelines. The history of nasal exposure to fresh water in the 14 days before symptom onset must be sought in patients presenting with meningitis or meningoencephalitis. So this 14 days is keeping primary amoebic meningoencephalitis in mind. If it is acanthamoeba, the incubation period we really don't know. The microbiology lab should be alerted in case of clinical suspicion. It is not that you can send for ask the microbiology lab to check for this trophocytes and they will be able to find. It's not so. They have to be alerted. It has to be a very fresh sample of CSF, which should be transported to the lab at the earliest. And your microbiologist has to be an expert, and they have to have this sort of very good patience to identify the motility of these trophocytes. The classical cases of Naegleria, etc., majority of the microbiologists may be able to identify. But acanthamoeba, the morphology, etc., keeps on changing, and only the microbiologists with real expertise will be able to identify the motility of trophocytes in case of acanthamoeba and all. In patients with clinical and CSF pictures suggestive of bacterial meningitis not responding to antibiotics, or those who are rapidly deteriorating, consider the primary amoebic meningitis even in the absence of epidemiological link. So this is important. That is, the picture suggestive of a bacterial meningitis, but you are not getting anything in culture or say PCR. Patient is deteriorating. Consider primary amoebic meningoencephalitis even if there is no epidemiological link. All cases of primary amoebic meningoencephalitis need not have a decrease in CSF sugar, that is hypoglycemia, RBCs, or neutrophilic pleocytosis initially. So classically, we were taught that so in the primary amoebic meningoencephalitis, definitely the CSF will be opalescent. It will mimic pyogenic meningitis. The sugar will be very low. The CSF will be RBCs, etc. Neutrophilic pleocytosis is mandatory. Nothing is actually mandatory in case of an amoebic meningoencephalitis. Depends on at what stage you are doing the CSF study. If you're diagnosing amoebic meningoencephalitis early, it might even mimic an aseptic meningitis or a viral meningitis, and certain cases even in cases where the amoeba PCR was positive, the CSF was absolutely normal. So all these things are from historical data that you need to think about amoebic meningoencephalitis only in case of a picture of pyogenic meningitis with the culture negativity. So all these things are just from literature. That is not what we are saying. The CSF wet mount examination to be done in all turbid or opalescent CSF samples. This is from CDC. The state guideline is that When in any case, when you are doing a CSF study, suspecting meningitis, meningoencephalitis, or encephalitis, irrespective of the epidemiological link, you have to ask for a CSF wet mount and ideally send a sample to the pH lab for PCR. If in doubt and the patient is deteriorating rapidly, so suppose you're having a child and who is deteriorating rapidly, don't wait for any results and you can start treatment empirically. Usually sporadic in case of clustering, the possibility of high risk behavior need to be explored. So after this vaping thing, so we in all cases, so young adults who is presenting with meningoencephalitis, we do aggressively ask for this history of vaping, and if that is present, it is a risk factor for amoebic meningoencephalitis. Excuse me. Now, based on our means experience, so we have added a bit to these guidelines. These are best practices. All cases diagnosed as primary amoebic encephalitis through CSF microscopy should be immediately initiated on recommended multi-drug regimen and supportive therapy aimed at lowering the intracranial pressure. Very, very important, especially in pediatric cases. Neurocritical care is of paramount importance. Sometimes, if the patient is not responding to your immunomodulators, that is dexamethasone and the cocktail of drugs, sometimes phenobarbital, coma, and all those things are very, very important. This neurocritical care is really important. A lot of children who survived this amoebic meningoencephalitis from SAT were in the ICU for more than 1 month. All cases diagnosed by CSF microscopy should be immediately informed to the DSO, and the CSF sample should be sent to reference lab for PCR and genomic sequencing if needed. And our reference lab as of now is our PH lab in Calicut. They are sending to PGI Chandigarh. So we need to send to, since VHCAN lab can do all this research, much easier for us to send it to the PH lab. If in all empirically treated case of tuberculous meningitis, wet mount should be performed to rule out granulomatous amoebic meningoencephalitis, because this amoebic meningoencephalitis is one of the DDs for chronic meningitis. Okay, this acanthamoeba meningitis can mimic tuberculous meningitis, and we all know that tuberculous meningitis initiation of ATTs is most often empirical. CB9 positive, it is tuberculous meningitis, but in a chronic meningitis, a lymphocyte predominant, sugar is low. Usually, we end up starting ATT empirically, and the lesion in the brain could be taken as tuberculoma. But chronic acanthamoeba meningitis can mimic tuberculous meningitis, and we had around 4 to 5 cases in the state where it was actually acanthamoeba PCR positive. And then certain things, which are not there in the CDC guidelines, we amended this year when this, the protocol was amended, or so the One Health, technical guidelines were released this year. These two points were added. A history of definite exposure to, excuse me, a history of definite exposure to fresh water could not be ascertained in certain cases of amoebic meningoencephalitis, and hence a CSF wet mount examination should be done for all cases of suspected meningitis or meningoencephalitis. As acanthamoeba and some other free-living amoeba can act as a Trojan horse, even if an alternate etiology like pneumococcus, gram-negative bacteria, or fungi is ascertained from CSF, a co-infection with FLA should be ruled out. In CDC, it is said that if you are getting an alternate etiology like a fungal meningitis or say a pneumococcal meningitis, etc., you need not think about an amoeba PCR and all those things. But our experience shows that all these things can coexist. Recently, one of our patients who died, unfortunately, it was a lady from Tamil Nadu. It's a late diagnosis, and it was actually acanthamoeba PCR positive, CB-NAT positive, as well as CSF had grown Aspergillus flavus from culture as well. So why this is happening? Because in the pond environment, this acanthamoeba is acting as a Trojan horse. Acanthamoeba actually feeds on the gram-negative bacteria, the cyanobacteria, E. coli, etc. So if the coliform count is high in any water body, in almost all our water bodies, the coliform count is high. If the coliform count is high, actually, the amoeba density in that ecosystem is also likely to be high. So this amoeba will phagocytose this bacteria like gram-negative bacteria like Pseudomonas, E. coli, then legionella phagocytose, then the algae in the pond is phagocytose, then the fungi, etc., are phagocytosed by amoeba. But as part of evolution, they have sort of acquired mechanisms through which amoeba won't be able to digest them. So all these things are living inside the amoeba, and when this amoeba reaches the CSF space, our macrophage will go and kill the amoeba, and all these things will come out. So if you're looking at your cocktail, this cocktail has antibiotics even against Legionella, antifungal drugs, etc. So So it is said that you can have polymicrobial infections in amoebic meningoencephalitis. The next point is if CSF Edmond demonstrate motile trophocytes and if PCR for Naegleria and Acanthamoeba are negative with FLA PCR positivity, the treatment cocktail should be optimized by institutional medical board based on clinical condition, so as to balance risk versus benefit. So I already said that now out of the 5 drugs which are using in the cocktail, it is basically aimed at Naegleria, of which 2 drugs are really toxic, like this amphotericin deoxycholate will lead to acute kidney injury, and multifosin, all the side effects we really don't know. It just actually marketed as a drug against CA breast, which was repurposed for leishmaniasis and all those stuff. Okay, so basically we really don't know. Suppose the patient is not that sick and all, and CSF is showing pictures suggestive of a viral meningitis like that, but if trophocyte is there and the PCR for amoeba is positive, then probably you can get away with a customized treatment using, say, fluconazole, azithromycin, cotrimoxazole, doxy, etc. So basically, if it is not Naegleria, based on the PCR positivity, you can use a customized treatment regimen. So that is the current guidelines. So based on the summary of cases from Trivandrum till September 2024, so the previously from North Kerala, it used to be a pediatric predominance, like so, whereas in all our cases, it was more in the young adults, so 27-year old. An interesting thing was, out of this around 10 cases admitted at that time, apart from the patient who died, all of the others were diagnosed pretty early, except one case. So they had only very mild symptoms. They had only mild fever, headache, and neck pain. And the CSF, the pleocytosis also was not very high. Okay, the trophocyte was there and the PCR was positive. That shows that if you're able to identify amoebic encephalitis at the earliest, there won't be that much CSF changes, and the outcome is also going to be great. So when we talk about the spectrum of amoebic meningoencephalitis, we already discussed. So primary amoebic meningoencephalitis is due to Naegleria, and granulomatous one could be due to Acanthamoeba, Balamuthia, Sapinia, Vermamoeba, and Francinae, Paravalcambia francinae. And interestingly, Paravalcambia francinae was diagnosed for the first time in 2009 in a patient who was suspected to have a viral meningitis. So CDC was actually collecting patients' CSF sample with viral meningitis, and they did a sequencing and they identified this Paravalcambia. And he said that Paravalcambia per se is not pathogenic. Instead, it harbors a bacteria which is pathogenic. And then the next question that we usually face is that you are saying that majority of your cases are due to Acanthamoeba, but then granuloma is not seen in the MRI. So this is the explanation. So if you are able to find this, the diagnosis at the earliest. So initially, this Acanthamoeba is getting into the CSF space. That is an angiogenic stimulus, and then there will be a cellular response, and then the granuloma will form. Suppose you are able to diagnose it earlier, you are not giving an opportunity for a granuloma formation to occur. So that is probably the reason why in cases where the diagnosis has been made early, so you are not able to find granulomas in MRI. And did we actually come out with all these conclusions? No. From 2023, we had multiple publications from Calcutta School of Tropical Medicine saying that a wet mount preparation of CSF must be a routine part of CSF examination. That is, they said that you should not ask for epidemiology link, because in majority of their cases they were not able to find an epidemiological link. So wet mount preparation CSF mandatory as a part of CS examination. They said that in globally 50 to 60 percentage. So in globally around 40 to 50 percentage of meningoencephalitis don't have a diagnosis. In India, only around 25% of meningoencephalitis has a diagnosis. So 75% we don't know a diagnosis. So it is mandatory that if you don't have a diagnosis, please rule out amoeba as well. Then, so that is the most important take-home message from that. And then in Trivandrum, we had changed the testing strategy. Once we changed the testing strategy, the epidemiology became very much confusing. That is, we changed the testing strategy means in some of the units, we started, sending this the PCR as well as the Bedmont for all cases of meningitis or meningoencephalitis. We did not look for any epidemiological link at all. And then we got a lot of surprising results, like in one case of longitudinal extending transverse myelitis, we got this PCR positivity. 2 cases of orbital apex syndrome sort of thing, we got this PCR positivity. So basically, we are in a the learning phase as far as this is concerned. And this aspect is also very important. Everything that is visible hides something that is invisible. So I will take you through one case to explain this thing. So this male came to us last year, 29-year-old, fever with chills, and features suggestive of acute meningoencephalitis. There was no history of bathing in ponds. At the time of admission, the GCS was E2, V3, M4, and he had neck stiffness. So he was an ethanolic smoker, and from the casualty itself, the resident got the history that he is a substance abuser and he used to do vaping. So vaping, as we know, is a risk factor for amoebic meningoencephalitis, right? And he had history of RTA in 2018, and he had sustained EDH, and there was a fracture in left orbital port of frontal vein. So any patient with a previous neurosurgery or say a head injury, there is always a chance of a CSF rhinorrhea or an unintact cribriform plate. They are at increased risk of developing this amoebic meningoencephalitis. And he did not have any comorbidities. And since he gave this history of vaping, from casualty itself, he was diagnosed as a probable case of amoebic meningoencephalitis. So he had a low GCS and increased optic nerve sheath diameter. He was intubated, mechanically ventilated, and CSF profile was suggestive of a probable bacterial meningoencephalitis. You can see there is hypoglycemia, sugar is pretty low, and the protein 1562 was initiated on ceftriaxone, vancomycin, and dexamethasone. And in view of history of vaping, the wet mount of CSF was done, and it showed the motile trophocytes, and the cocktail was initiated. And since we aggressively look for other etiologies as well, the multiplex PCR panel had been sent to IAV, which showed pneumococcal PCR positivity. And the CSF amoeba PCR panel, at that time we used to send it to PS Lab, had not started the PCR testing, so we sent it outside to PGI Chandigarh, and it came as Acanthamoeba neglaria and Balamuthia were negative. And MRI brain showed features of meningoencephalitis with patchy involvement of occipital, frontoparietal, and splenium of corpus callosum, and he was in a pretty bad state. And we know that it could be a Trojan horse. So basically, pneumococcus is there, and we got the trophocytes as well. And as discussed, Acanthamoeba, Vermamoeba, and Paravalcampia can act as a Trojan horse like vehicle for pathogenic microbes like Legionella, Pseudomonas, Aeromonas, Mimivirus, even atypical mycobacteria, fungi, as well as algae like Prototheca. And we were expecting these pathogens. These are the classically described pathogens that we should be expecting in inside Acanthamoeba. But here what we got was pneumococcus. Okay, so suppose any patient presenting with features suggestive of a pyogenic meningitis, and you are getting pneumococcus from PCR, I don't think anyone will think beyond that, right? But Acanthamoeba can harbor pneumococcus as well, based on a lot of studies are showing that the Streptococcus pyogenes as well as pneumococcus remain viable during encystation process. So if there is the risk factor, even in case of pneumococcal meningitis, we need to think about amoebic meningoencephalitis as well. And but our PCRs were negative. But at that time, in AB Institute Pondicherry, Dr. Ragaj Segal is a retired HOD from PGI Chandigarh. He was doing this free living amoeba PCR. So the FLA PCR came as positive. So basic diagnosis was he is having a co-infection of pneumococcus with free living amoebic meningoencephalitis. And gradually, he recovered. After 3 weeks, we were able to get him out of the ventilator. And CSF study after 2 weeks showed biochemical improvement. You can see no cells, the sugar had improved, the protein had come down from 1600 to 60, but the motile trophocytes were still present, but the pneumococcal PCR had become negative. So he was continued on the rest of the regimen except amphotericin, because amphotericin was stopped because of acute kidney injury. Then after 45 days of hospitalization, he was discharged on cotrimoxazole and doxycycline, because even at the time of discharge, the trophocytes were still positive, and the CSF became negative only after 60 days. So he was actually put on cotrimoxazole and doxycycline and was discharged. So basically, this is what is meant by customized treatment. So this actually highlights the importance of molecular diagnostic tools in optimizing targeted treatment of patients with meningoencephalitis. And even if you're having a diagnosis of some bacterial etiology, if the patient is not really improving, you can think about an associated FLA meningoencephalitis as well. Then actually, this we were also a lot confused, because you are having 30 cases in one medical college in 1 year, that too within 3 months. And your mortality is pretty low, and it is not as per literature, because at one point of time, Trivandrum had 29 cases with just one mortality, right? So that is, sort of unexpected. Even though we can say that it's due to early diagnosis, etc., something was amiss. So we are having cases only in Calicut and then in Trivandrum, and in early diagnosis, the mortality was low. So the questions that we asked ourselves were: is it the change in testing strategy that has led to an increased case detection in GMC Trivandrum? Because we were looking for amoeba in all cases of meningoencephalitis. Second is, if so, are the other centers missing cases of amoebic meningoencephalitis since they are not looking for it? Then why apparently the missed cases of amoebic meningoencephalitis are not resulting in increased mortality among undiagnosed meningoencephalitis cases? Suppose some medical college is not aggressively looking for amoebic meningoencephalitis, but then the mortality should be higher, right? So then actually we learned a lot from a particular lady. This is a 28-year-old lady with non-comorbidities was presented with acute meningoencephalitis, and you can see the CSF study was suggestive of pyogenic meningitis. 1,700 cells with low glucose and protein was also elevated, but wet mount did not show any trophocytes, and the MRI brain was suggestive of cerebralitis. But still, apparently the CSF had been sent for the PCR because they had some doubt whether trophocytes were there or not, but it was not reported. And then at that time, we used to get this PCR report after 1.5 months and all. So this lady was treated with ceftriaxone, doxycycline, vancomycin, and initial 4 days had received dexamethasone as well. And then after 1.5 months, we got the report saying that this patient also the PCR is positive for free living amoeba, and we were really confused because we never thought that this lady was having amoebic meningoencephalitis, and we called her up, and then we realized that she was perfectly normal. Okay, then we got her admitted again, and the repeat MRI had been done one month after discharge, and that showed resolution of the cerebellar lesions. And the repeat CSF study we did after getting her admitted again, that was perfectly normal, and the trophocytes were not there. Then we realized that certain cases, if it is not Naegleria or to an extent Acan amoeba, the other patients with other free living amoeba may be improving with the treatment that we are giving for the viral meningitis or meningitis where we don't have a diagnosis. Like all the patients will receive ceftriaxone, dexamethasone, doxycycline for 14 days. Okay, and then a literature search revealed that even ceftriaxone and doxycycline does have in vitro anti-amoebic activity, and probably that is the reason why out of 10 cases of maybe meningoencephalitis, maybe one may be Naegleria that might die if you are not picking up, and two may be Acanthamiba that might lead to complications in immunocompromise. But the other 7 may be without our knowledge getting treated. So with ceftriaxone and doxycycline. So these are the main components of the action plan. So we know that it should be tackled with a One Health approach, because water bodies etc. can be tackled only by the LSGD and all. So the public awareness campaigns is very, 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 very important. Yeah, even now we have a 3-month-old child in Calicut Medical College, 3-month-old child in Calicut Medical College with Naegleria meningoencephalitis, and in such cases we should be knowing the risk factors, and there is a practice of putting this holy water into the nose, etc. So despite I think that the awareness had been conducted multiple times across the state, but still this practice of using unsterile or say this thing dirty water into the nose, etc. is happening in multiple centers, even in neonates as well. So there is a role for public awareness campaigns. Then enhancing the diagnostic capacity in that aspect, state has done a wonderful job in empowering the PS lab with all the 5 primer kits. PS lab can diagnose 5 species of free living amoeba, and also the microbiology departments at Calicut and Trivandrum has been it has been decided to make it center of excellence for parasitology. Then active case surveillance, very, very important. Don't think that all the patients will be having an epidemiological link. Any case of acute encephalitis, meningitis, or meningoencephalitis, actually, as per the state guidelines, it is better to alert your microbiologist and ask for a wet mount examination. Environmental surveillance and hotspot mapping. So especially in case of Naegleria, so if you are identifying a case of Naegleria meningoencephalitis, you are supposed to find the source, and then that source actually it has to be chlorinated, sometimes super chlorinated, to ensure 0.5 to 1 milligram per liter of residual chlorine, and then only that should be open for public use. Treatment and drug availability, another area where state has been so supportive, because multifosin probably may be the game changer, because Prior to advent of miltefosine, we have been treating this Naegleria with other drugs with no success rate. I really don't know whether it is the miltefosine alone or the use of immunomodulators along with these 5 drugs, which has resulted in very good outcomes. But according to our pediatric critical care specialist Srija Madam, the early diagnosis is the one which really improves the outcome. Then definitely research and collaborations very, very important. And this article from PGI Chandigarh in 2022, it has to be an eye opener for all of us. Okay, so they actually in 156 patients with meningitis or meningoencephalitis, where all other causes have been ruled out, they did this amoeba PCR, amoeba means culture, as well as the wet mount examination. And out of 156 samples, they identified 11 positive samples, 6 acanthamoeba, 3 Balamuthia, and 2 Naegleria fowleri. So basically, if you actually bring it down to say 100 patients, around 8 patients with undiagnosed meningitis or meningoencephalitis in our country may be having amoebic meningoencephalitis. So that clearly explains this. You have the PGI their own data saying that out of say 156 samples, 11 were undiagnosed cases of amoebic meningoencephalitis. You have literature from the East India, that is from Calcutta, etc., showing that in all cases of meningoencephalitis, you need to do the wet mount, and there is no a point in doing this wet mount only for patients with epidemiological link. So it is just like a triangle: Punjab on one side, the Calcutta on the other side, and Kerala on one side. That means the other states are missing it, and Kerala is aggressively diagnosing cases of amoebic meningoencephalitis. So these are the acknowledgements, for data. It's thankful to the health, the state health department, the DHS, ADHS, and everyone, and Dr. Rakesh Segal sir from Pondicherry for helping us with diagnosis. Dr. Sumit Horana, she is actually head of parasitology at PGI Chandigarh. Sunija madam from the state PS lab, because that has been a game changer. Now in Trivandrum, within say one day, you are getting all the PCR positivities, and even in cases where the trophocytes are not visible, the PCR is becoming positive. So that should be the way. I think one case from one private hospital in Thrissur district had they suspected this. They suspected means there was a sort of an eosinophil meningoencephalitis patient was a very bad shape. They were not able to identify the trophocytes, but they sent the sample to PS lab, and Naegleria was identified, and the patient was discharged from, I think, another private hospital after 1.5 months of ICU care. So early diagnosis on Naegleria definitely translates to very good patient outcomes. Having said that, it is just like building bridges as we walk. A lot of things we really have not understood, because more we are looking for amoeba, we are finding cases where we rarely means are expecting the presence of acanthamoeba or say paravalcamphy, etc. So we have 2 cases of orbital apex syndrome where this acanthamoeba PCR has come as positive. So basically, we are learning day by day. And only the message I would like to convey is that in any case of meningoencephalitis, it will be prudent to do the wet mount examination. So thank you very much for the opportunity.
Thank you, Dr. Aravind, for the excellent presentation covering all the aspects. If you have any queries, you can just unmute and ask. So as you said, we have around 75% of undiagnosed AES, and now do you think this increase in cases of this amoebic meningitis, meningoencephalitis is due to increase in diagnosis?
Actually, that has to be the case, because now still now there is a squeeze. Random is diagnosing a lot of cases, and Calicut Medical College is diagnosing a lot of cases. Basically, you're looking for it means you're diagnosing it. So previously there was like confusions, like it's not easy to diagnose Naegleria. Okay, the morphology is easy, but acanthamoeba, you have the welfare state, you have the stress state, etc. Only experienced microbiologists will be able to identify all the cases. But now we are having PCR, and all these things are being corroborated by PCR evidence. So and that is why we are getting more and more confused. Orbital apex syndrome with academia PCR positivity, like that. So more and more, you improve your diagnostic capacity, more and more cases you are likely to find. That is why I said, whatever Kerala is doing is reinventing the wheel. This is what PGA had said. They had actually this published it, but they did not take it into a public health sort of approach into it. Okay, I don't think even they are aware of the importance of their publication, saying that 8% of undiagnosed meningoencephalitis is probably due to academia. It's a profound statement, right? The publication. And that is exactly what the School of Tropical Medicine from West Bengal also said. That is, there is no point in looking for epidemiology because majority of the cases they diagnose as amoebic meningoencephalitis, they were not able to find an epidemiological link. Why? Because they were looking at epidemiological link as a history of a bath in a pond. Whereas we are saying that if you are using a well water, that is an epidemiological link. If you are taking a bath, that is an epidemiological link. That is how we know Kerala is approaching the problem. And that is why the state guidelines clearly say that even if you don't come across classical risk factors, means it is prudent to ask your microbiologist to do a wet mount examination if you are suspecting meningitis or meningoencephalitis or encephalitis.
One question is in the chat. What is the name of the lab where you can send PCR?
Public Health Lab, Trivandrum.
So
PH Lab Trivandrum. And actually, if the question is from a doctor working in the private hospital, you can contact the DSO, District Surveillance Officer.
can you also tell the procedure of sending the CSF? Any particular thing to do with this?
The most important thing is that it has to be a fresh specimen of CSF. You should not refrigerate because the moment you put it in the fridge, this amoeba is thermophilic, right? Especially in Naegleria. So if you are sending a refrigerated sample, you are unlikely to find this thing viable trophocytes. So basically, you alert the microbiologist that you are going to do a CSF study, and immediately get it into the microbiology so that they can do this CSF wet mount, and the technique etc. are clearly given in the our state guidelines. Okay, and I think the PH lab has given a circular to all the districts how this sample can be sent to the PH lab. There also ideally it has to be sent as early as possible.
Will chlorination kill the amoeba?
Actually, chlorination will kill amoeba, but acanthamoeba cyst is going to be a problem. The Naegleria, you are having a cyst form, and you are having the trophocytes and a flagellated form. The Naegleria, since it is a rapid course inside the human body, there is no encystation. There is no time for encystation because usually everyone dies. But the situation in Kerala is different. Whereas acanthamoeba, this encystation will happen, and chlorine may not be that successful against this encysted form of acanthamoeba, but the trophocytes etc. will be killed by chlorine, and the concentration varies. For example, we say that in the drinking water system, okay, like our corporation water etc. Throughout, we need to maintain around the residual chlorine level of 0.5 milligram per liter. But suppose you are identifying Naegleria from the drinking water system that has been identified from US itself, right? So we will also maybe having Naegleria. Then this concentration could be as high as 1 milligram per liter. Whereas in swimming pools, water theme parks, etc., the level of residual chlorine should be between 1 to 3 milligram per liter. Okay, so like that. And suppose your this 0.5 this thing is not working, then you need to ensure 1 milligram per liter of residual chlorine in the wells. So that is something we can do. But initially, we were really surprised that a lot of cases, majority of the cases, were having wells at home. The problem is that there are 65 lakh open wells in Kerala, so we can't just blame wells for this, right? And whenever we sample the wells, we got this acanthamoeba, paravalcampia, etc. So it's not surprising because these are supposed to be there in all the water bodies. Then there was sort of skewing, like some of the private hospitals are also sending PCRs regularly to PH lab, and they were not able to diagnose any case. Okay, whereas the government medical colleges were able to diagnose it. Then so we realized that the patient profile coming to the government hospitals and the corporate hospitals are a bit different. Okay, so basically the poorer patients are the ones who are developing this one because they are the ones who are likely to get exposed to all these contaminated water bodies, and the wells that we have at home actually does not have clear water because our density of population is pretty high, and the coliform counts in, I think there was a study done by the pollution control board, 80% of the wells, the coliform count was pretty high. And then we actually asked them to look at the amoeba density sort of thing because such a thing is there in Queensland, Australia. This thing, like they look at the amoeba density in water bodies. Then our pollution control board said that there is no point in looking for amoeba density in the presence of coliform count. If coliform count is high, you have to assume that amoeba is there. Okay, so you can take coliform count as a surrogate marker of the presence of amoeba. But then everything is based on the presence of Naegleria, because Acanthamoeba, no one used to give that much importance. But so majority of the cases of amoebic meningoencephalitis in the state now happens to be due to Acanthamoeba, and that is why we have changed our attention to the wells, and we are insisting that the well should be chlorinated every 3 months or so. Overhead water tanks is another problem like that. ഇതിൽ ഏറ്റവും വലിയ പ്രശ്നം നമ്മളിത് ട്രീറ്റ് ചെയ്യാതെ തന്നെ അറിയാതെ തന്നെ ട്രീറ്റ് ചെയ്ത് പോകുന്നുണ്ടെന്ന് തോന്നുന്നു. കാരണം ഇമ്മ്യൂണോ കോമ്പീറ്റന്റില് ഈ സെപ്രാക്സോണും ഡോക്സിയും കുറച്ച് സ്റ്റിറോയിഡും വെച്ച് തന്നെ ഒരു 14 days വെച്ചിട്ട് ഒത്തിരി പേര് ഇമ്പ്രൂവ് ചെയ്ത് പോയിട്ടുണ്ട്. പിന്നെയാണ് നമ്മളിത് PCR കിട്ടിയത്. അതുകൊണ്ടായിരിക്കാം ബാക്കിയുള്ള സ്ഥലങ്ങളിൽ അറിയാതെ ട്രീറ്റ് ചെയ്ത് പോകുന്നുണ്ടായിരിക്കും. ഓക്കെ,
നമ്മള് ഗ്ലോബൽ വാർമിങ്ങിന്റെ പുറത്തുകൊണ്ട് വെച്ചല്ലേ കിടക്ക്.
എക്സാക്ട്ലി. കാരണം ഇപ്പം നമുക്ക് കിടക്കുന്ന ഒരു പേഷ്യന്റ് വന്നത് ബൈലാറ്ററൽ പാപ്പിലോഡിമയായിട്ട്. ഷീസ് എ 26-year-old ലേഡി. ബൈലാറ്ററൽ പാപ്പിലോഡിമയാണ്. ദ ഇനിഷ്യൽ CSF വാസ് അറൌണ്ട് 110 cells ഉണ്ടായിരുന്നു, പക്ഷെ ഒന്നും കിട്ടിയില്ല. പിന്നെ അതിന്റെ ഡയമോക്സ് ഒക്കെ സ്റ്റാർട്ട് ചെയ്തു, ഇഡിയോപ്പതിക് ആണെന്നൊക്കെ പറഞ്ഞിട്ട് ഇൻട്രാക്രൈനൽ ഹൈപ്പർടെൻഷൻ. പക്ഷെ 1 month ആയിട്ടും ഈ പാപ്പിലോഡിമ മാറുന്നില്ല. അത് CSF പ്രഷറൈസ് ആയി. ബട്ട് ദെൻ ദ CSF അതർവൈസ് ദ സെൽസ് എക്സെട്ര ആർ നോർമൽ സോർട്ട് ഓഫ് തിങ്. അപ്പം ഇത് അമീബിക് ആണെന്ന് പറഞ്ഞ് പലവട്ടം നോക്കിയപ്പോൾ ഒരു പ്രാവശ്യം എന്തോ ട്രോഫോസൈറ്റ് ഉള്ള പോലെ തോന്നി. പക്ഷേ PH ലാബിൽ അയച്ചപ്പോൾ ഇൻഡിറ്റർമിനേറ്റ് ആയിട്ട് അക്കാന്തമീബ വന്നു. പക്ഷേ അത് ഇപ്പോൾ CT വാല്യൂ ഹൈ ആയതുകൊണ്ട് ദേ ഡിഡ് നോട്ട് റിപ്പോർട്ട് ഇറ്റ്. പക്ഷെ ഇവര് ഈ കിണറ്റിൽ ഈ ഫിഷിനെ വളർത്തുന്നുണ്ട്. അതാണ് ഇപ്പോഴത്തെ ഒരു പുതിയൊരു ഹോബി. കിണറിൽ ഫിഷ് വളർത്തുന്നുണ്ട്. അപ്പോൾ ഫിഷ് വളർത്തിയുള്ള പ്രശ്നം എന്ന് വെച്ച് കഴിഞ്ഞാൽ ഒന്ന് ബയോ ബർഡൻ കൂടെയാണ്, കോളിഫോം കൗണ്ടൊക്കെ കൂടും. Second thing is that they won't chlorinate. If you chlorinate this thing, the fish will die. So they will use potassium permanganate. So potassium permanganate, whether it has any activity on amoeba, I don't know. Okay. But anyway, well water നമ്മുടെ ഡിസ്ട്രിക്ട് ടീം എടുത്ത് നോക്കിയപ്പോൾ അതിൻ്റെ അകത്ത് അക്കാന്തമിയോ പാരവാൽക്കാമിയോ കിട്ടി. ബട്ട് ദാറ്റ് ഡസ് നോട്ട് മീൻ എനിത്തിങ്. കാരണം പേഷ്യൻ്റിൽ നിന്ന് കിട്ടിയില്ലല്ലോ. ബട്ട് അപ്പോഴേക്കും ഈ പേഷ്യൻ്റെ സിംറ്റംസ് കുറയാത്തതുകൊണ്ട് വി സ്റ്റാർട്ടഡ് ദ കസ്റ്റമൈസ് ട്രീറ്റ്മെന്റ് അഗെയിൻസ്റ്റ് അമീബിക് മെനിഞ്ചോഎൻസെഫലൈറ്റിസ്. വി വോണ്ട് ഗീവ് ദിസ് തിങ് വാട്ട് multifosin and amphotericin we won't give. Instead, we started with ceftriaxone, azithromycin, fluconazole, and cotrimoxone. And the patient started improving. And then what we do is, on 14th day, we will actually repeat the CSF. In the PCR, ഒന്നും കൂടെ അയച്ചപ്പം അത് അക്കാന്തമിയോ PCR പോസിറ്റീവ് ആണ്. ഓക്കെ, സോ ബേസിക്കലി ഇങ്ങനെ ഒത്തിരി കേസ് ഉണ്ട്. അപ്പോൾ ഇത് നമ്മൾ ട്രീറ്റ് ചെയ്തില്ലെങ്കിലും ചിലപ്പം മീൻസ് കുറച്ച് കഴിയുമ്പോൾ ബാക്ടീരിയൽ ആണെന്നൊക്കെ പറഞ്ഞ് ഈ സെപ്രാക്സോൺ ഡോക്സി ഒക്കെ കിട്ടിയെങ്കിൽ പോകും. അത് നമ്മൾ അറിയില്ല. പക്ഷെ പീഡിയാട്രിക് പോപ്പുലേഷനിൽ ഇഫ് യു മിസ് ഇറ്റ് ദ ചൈൽഡ് വിൽ ഡൈ. ബിക്കോസ് ചെറിയൊരു മീൻസ് സെറിബ്രൽ എഡീമ വന്നാൽ തന്നെ പേഷ്യൻസ് ആർ ലൈക്ലി ടു കോൺ. So Naegleria won't get time. Acanthamoeba, etc., you might get time. But if there is a delay in diagnosis, from our experience, it takes a long time for the trophocytes to be cleared from the CSF. So might require months of treatment. Granulomega vannu kayinjal the duration of treatment we really don't know. So we keep on giving the drugs like doxycycline, cotrimoxole, etc., and based on imaging clearance only we stop.
Okay. Dr. Abhilash is here. Abhilash, who is a consultant physician as well as a team member of our academic side.
One question is prophylactic medicine. So there is no prophylactic medicine as such. Filters, will it eliminate? This is a big organism. To an extent, it might. That's the only thing we can say. Only when a person develops symptoms, CSF study is done. Since mortality is very high, any method to diagnosis when we get a history of swimming in an asymptomatic child. Asymptomatic child, please don't worry about it, because only the symptomatics will progress and die. So please don't worry about the asymptomatic people. That is the importance of customization. So if the child is symptomatic, there are lot of there are millions of children who are using all these things, right? Now only if you are developing the disease. So we should not be spreading any scare or anything. What we try to convey is that if someone is developing symptoms of meningitis or meningoencephalitis, please do think about it. അല്ലാതെ അസിംറ്റമാറ്റിക് ആണ് നോക്കേണ്ട കാര്യമില്ല. മാത്രമല്ല മുമ്പ് തന്നെ there are studies showing that in children who are living near water bodies and all, this amoeba colonization in the nose is around 2%. That is colonization, that is not invasion. So when nasopharynx throatil ഒക്കെ തന്നെ this free living amoeba colonization, there are a lot of studies. അതിന് പ്രശ്നമൊന്നുമില്ല. Only thing is that once they develop the meningeal signs, we should be able to diagnose at the earliest. നമ്മുടെ സ്കെയർ ഒന്നും പാടില്ല കേട്ടോ. കാരണം ഇതിപ്പോഴും പലരും പറഞ്ഞു, ഇപ്പം ഈ അമീബ എന്ന് പിന്നെയും പേപ്പറിൽ വന്നപ്പോൾ ഈ സ്വിമ്മിംഗ് പൂളിൽ നിന്നും ആരും പോകുന്നില്ല. Properly chlorinated swimming pool is a very safe place. Okay, but that is not the message we are trying to convey. Okay, അപ്പം നമ്മളെ ഒരിക്കലും ഒരു മീഡിയയിൽ വരുന്ന അനുസരിച്ച് നീച്ചർക്ക് റെസ്പോൺസ് അല്ല വേണ്ടത്. ലൈക്ക് there has to be a scientific way. Like if you are swimming, nasal plugs യൂസ് ചെയ്യണമെന്ന് പറയുന്നു. ഇതൊക്കെ തന്നെ ഇന്റർനാഷണൽ യൂസ് ചെയ്യുന്നതാണ്. അപ്പൊ അതൊക്കെ ഓക്കെ തിങ്സ്. വാട്ട് അബൌട്ട് nasal installation of water, nasal ablution and all those stuff? These are things which are directly introducing this amoeba into the cribriform blade, right? Adine we should be taking the lead in creating awareness sort of thing. Will boiling water kill amoeba? It will kill amoeba. Last year 39 cases, 8 died, others served. Is it correct? Yes, it is correct. Okay. 23% mortality. So 39 cases, I think 9 died. So that is 23%. And all others survived. Yeah, that is correct. This year also the figure is almost the same. There is around 25% mortality is there. 25% varanulla karanam, this year we resorted to aggressive testing, and we got in one patient with hepatic encephalopathy also we got amoeba, and he died. I don't know whether he died because of amoeba or hepatic encephalopathy, and that will add to the mortality. Okay.
Dr. Abhilash, any comments?
Hello, namaskaram. As usual.
അഭിലാഷ്, നമ്മുടെ അഭിലാഷ് ആയിരുന്നല്ലേ? എനിക്കത് പെട്ടെന്ന് മനസ്സിലായില്ല.
നമ്മളതിൽ അമീബിക് എൻകെഫലൈറ്റിസ് നമ്മളെ നഴ്സറിയിലാണ്. ഇപ്പൊ ക്ലാസ് കഴിഞ്ഞപ്പോ ഏതായാലും ഒരു 1ാം ക്ലാസ്സിലോട്ട് എത്തിയിട്ടുണ്ട്. ഡോക്ടർ എന്ന് പറഞ്ഞ പോലെ ലേണിംഗ് പ്രോസസ്സിലാണ്. ക്ലാസ് ഏതായാലും നമുക്ക് പുതിയ നോളജ് ഇതിനെ കുറിച്ച് തന്നിട്ടുണ്ട്. തീർച്ചയായിട്ടും നമ്മൾ പ്രാക്ടിക്കലി അപ്ലൈ ചെയ്യുന്നതായിരിക്കും.
നമ്മള് ഈ ഇപ്രാവശ്യത്തെ ഇതിന്റെ പ്ലാനിൽ ഒന്ന് പറഞ്ഞിരിക്കുന്നത്, ട്രിവാൻഡ്രത്തെയും കാലിക്കറ്റിലെയും മൈക്രോബയോളജിസ്റ്റ് ഒരു ഡിജിറ്റൽ ലൈബ്രറി പോലെ അവരുടെ ഉണ്ട്. അത് വെച്ച് ബാക്കിയുള്ള മൈക്രോബയോളജിസ്റ്റിനെ ട്രെയിൻ ചെയ്യണം എന്നുള്ളതാണ്. കാരണം നമ്മൾ കൺവെൻഷനലി കാണുന്ന ഫോംസ് അല്ല പലപ്പോഴും ഡയഗ്നോസ് ചെയ്യപ്പെടുന്നത്. ഈ 2023 വരെ ഒരു ക്ലാസിക്കൽ, അതായത് നമ്മളൊരു നെഗ്ലേറിയ എന്ന് ആര് കണ്ടാലും പറയുന്നത് മാത്രമേ ഡയഗ്നോസ് ചെയ്തിട്ടുള്ളൂ. ഈ നെഗ്ലേറിയ ക്ലാസിക്കൽ ഫോമിൽ തന്നെയാണ് ഇരിക്കുന്നതെങ്കിലും ഈ അക്കാൻഡമീബയും RBCയും തമ്മിൽ ഡിഫറൻഷിയേറ്റ് ചെയ്യാൻ അത്ര ഈസി അല്ല. ഈ ചെറിയ അക്കാൻഡമീബ ആണെങ്കിൽ അതിൻ്റെ അകത്ത് പ്രോട്ടോപ്ലാസ്മിക് മോട്ടിലിറ്റി ഒക്കെ വേണം. അപ്പം ഇവര് ട്രോഫോസൈറ്റ്സ് കാണുന്നത് വേറെ ആൾക്ക് അയച്ചു കൊടുത്താൽ അവർ നെഗറ്റീവ് എന്ന് പറയുന്ന പല സിറ്റുവേഷൻ ഉണ്ട്. പക്ഷെ ഇതെല്ലാം PCR പോസിറ്റീവ് ആണ്. സോ വി റിയലൈസ് ദാറ്റ് അതർ മൈക്രോബയോളജിസ്റ്റിനും ട്രെയിനിങ് ഇല്ലാതെ ചിലപ്പം കണ്ടുപിടിച്ചെന്ന് വരത്തില്ല. സോ ദാറ്റ് ഒരു ഡിജിറ്റൽ ലൈബ്രറി പോലെ ഇവർ രണ്ടുപേരും ഉണ്ടാക്കുന്നുണ്ട്, കാലിക്കറ്റും ട്രിവാൻഡ്രവും. With that, I think all the microbiologists will be trained. Another important thing is that customization of treatment is very, very important, because this amphotericin, multifosin, etc. are toxic drugs. Okay, അപ്പം ഒരു വലിയ കുഴപ്പമില്ലാത്ത ഒരാൾക്ക്, അതായത് you are having a viral meningitis sort of picture and acanthamiba is positive, അവരങ്ങനെ അഗ്രസീവ് ട്രീറ്റ് ചെയ്ത് കഴിഞ്ഞാൽ the drugs might do more harm than the disease. So that is the importance of customization. Negleria definitely, അല്ലെങ്കിൽ സിക്ക് ആണ്, ഇപ്പം GCS less than 8 ആണ്, you need to be very, very aggressive. There are a lot of cases where you are having this acanthamiba PCR positivity, but the GCS is pretty good and ICP is not very high. അവിടെ really customization is required, because നമ്മുടെ the initial cluster we had means around 10 cases, 7 were from the one cluster. So at that time we thought that നമുക്ക് ആരെയും എക്സ്പീരിയൻസ് ഇല്ലല്ലോ last year. So we gave this cocktail to all the patients, and 2 of them ended in dialysis. Okay. So that is the thing, because we thought that the patient will worsen, like that. Nothing happened. But basically, the clinical decision, neurocritical care, optic nerve sheath diameter, you can use a combination of less toxic drugs also. In pediatrics, I won't advise this, because pediatric the monitoring is not that easy, and suddenly they might go in for coning. But in adults, this is possible. Customization is possible.
So what about the availability of these drugs?
Availability, multifosin, the government is supplying. So actually, even though ceftriaxone is not part of the cocktail, we are continuing ceftriaxone, because initially, since till we get the diagnosis, ceftriaxone will be there for all cases of meningitis or meningoencephalitiis. So we are not stopping it, because that's from our experience. And നമ്മൾ പലതും PCR പിന്നെ വന്നപ്പോൾ നമ്മൾ ട്രീറ്റ് ചെയ്ത്, നമ്മൾ അറിയാതെ ട്രീറ്റ് ചെയ്ത് ഇമ്പ്രൂവ് ചെയ്ത് പോയ പേഷ്യൻസ് ഉണ്ടല്ലോ. അപ്പോൾ അവർക്ക് കിട്ടിയത് ceftriaxone ഡോക്സി ആയിരുന്നു. okay, and Dexona. So ceftriaxone has excellent CSF penetration also. When you are looking at the 5 drugs in the cocktail, amphotericin deoxycholate is toxic only for Naegleria. Academia does not require amphotericin. Miltefosine is an excellent drug, but you know the CSF penetration of miltefosine is not great. Even though we say that that is the drug which changed everything, the CSF penetration is not really great. The parenchymal penetration is excellent. Then you are looking at azithromycin. Azithromycin has activity against Acanthamiba, but you know compared to doxy, the penetration, even penetration of doxy is only 26%. CSF penetration of azithromycin is not really great. Fluconazole has excellent CSF penetration. Rifampicin is not easy to get. RNDC ടി ബി അല്ലാതെ തരില്ല. കഴിഞ്ഞ വർഷം ഈ അമീബ എന്ന് പറഞ്ഞാൽ എന്ത് നമ്മൾ ചോദിച്ചാലും കിട്ടുമ്പോൾ റിഫാംബൈസിൻ കിട്ടുമായിരുന്നു. നൗ ആക്ച്വലി rifampicin കിട്ടിയില്ലെങ്കിലും we are using cotrimoxazole because cotrimoxazole has excellent activity against Acanthamoeba. So cotrimoxazole we don't use for Naegleria, but for Acanthamoeba we use cotrimoxazole. അപ്പോൾ ഇതിൽ ഡ്രഗിന്റെ അവൈലബിലിറ്റി മൾട്ടിപോസിൻ ആണ് കിട്ടാൻ പാട്. ദാറ്റ് ഈസ് എൻഷുർഡ് ബൈ ദ ഗവൺമെന്റ് ഓഫ് കേരള. അത് കിട്ടും, ഫ്രീ ആയിട്ട് കിട്ടും. അത് കാലാസ പ്രോഗ്രാമിൽ നിന്നാണ് കിട്ടുന്നത്. അപ്പോൾ ഷോർട്ട് എക്സ്പയറിയാ തരുന്നത്. എന്നാലും അവർ ദ DHS ടീം ഈസ് സോ ഗുഡ് ദാറ്റ്സ് മൾട്ടിപോസിൻ. അത് നമുക്ക് മാത്രമേ അമീബയ്ക്ക് വേണ്ടി കിട്ടുന്നുള്ളൂ കേട്ടോ. അതർ സ്റ്റേറ്റ്സിന് അമീബയ്ക്ക് വേണ്ടി മൾട്ടിപോസിൻ കിട്ടില്ല. അവർക്ക് ലീഷ്മേനിയയ്ക്ക് വേണ്ടി മാത്രമേ കിട്ടുള്ളൂ. Use of nasal plugs during swimming can prevent amoebic encephalitis. So nasal plug can prevent the entry of the water into the this thing, that cribroplate prevent ചെയ്യാൻ പറ്റും. രണ്ട് കാര്യം പറയുന്നത്, യൂസ് nasal plugs and if possible keep the head above water while swimming. എനിക്കറിയില്ല അതെങ്ങനെയാണ്, എന്നാലും അതാണ് എല്ലാ ഗൈഡ്ലൈൻസും പറയുന്നത്. നേസൽ പ്ലഗ്സ് ആൻഡ് കീപ്പിംഗ് ദ ഹെഡ് അബോവ് വാട്ടർ വൈൽ സ്വിമ്മിങ്. പിന്നെ വേറൊന്ന് ഡൈവിങ് അവോയ്ഡ് ചെയ്യാൻ നോക്കാം. ഡൈവ് ചെയ്യുമ്പോൾ കയറും.
എന്തെങ്കിലും ക്വറീസ് ഉണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം. ബിനു കൃഷ്ണൻ സാർ എന്തെങ്കിലും പറയുന്നോ?
Liposomal amphotericin can also be used. This is a question. ഇതിലൊരു പ്രശ്നം എന്ന് വെച്ച് കഴിഞ്ഞാൽ for all other indications liposomal amphotericin is as good as deoxycholate. It is less toxic and very easy to tolerate. പക്ഷേ unfortunately for Naegleria, the MIC of liposomal amphotericin is 10 times that of deoxycholate from the available literature. അതുകൊണ്ടാണ് deoxycholate is preferred എന്ന് പറയുന്നത്. And that too for Naegleria, deoxycholate the dose is 1.5 mg per kg for 3 days. Usually mucorneka 1 mg use it, and for 14 days you need to give 1 mg per kg, and if there is no response, intrathecal ഒക്കെ ട്രൈ ചെയ്യാന്ന് പറയുന്നുണ്ട്. നമ്മൾ ഇൻട്രാതീക്കൽ വെരി ബാഡ് പേഷ്യൻസിനെ യൂസ് ചെയ്തിട്ടുള്ളവരൊന്നും സർവൈവ് ചെയ്തിട്ടില്ല. ഇപ്പോൾ liposomal amphotericin എവിഡൻസ് ഇല്ല, ബട്ട് it is Naegleria and deoxycholate cannot be used, then you can try liposomal amphotericin. ഡേറ്റ ഇല്ല. It should actually work. Any case proven without swimming in contaminated water. A lot of cases there is no contact with any of this contaminated water or anything. That's the problem. So that is what in 2023 onwards, the School of Tropical Medicine people were saying. In all the cases they could not find any contact. So this question clear ആണ്. We think that swimming in a pond or contaminated water മാത്രമാണ് റിസ്ക് ഫാക്ടർ. അങ്ങനെ അല്ല. മീൻസ് റിസ്ക് ഫാക്ടേഴ്സ് നോക്കുമ്പോൾ മീൻസ് വാട്ടർ, ഓൾ സോർട്സ് ഓഫ് വാട്ടർ കോണ്ടാക്ട് കാരണം ഇത് വരാൻ പറ്റും. സം പീപ്പിൾ അപ്പിയേഴ്സ് ടു ബി മോർ സസെപ്റ്റബിൾ ടു ദിസ് തിങ്. വൈ വി ഡോണ്ട് നോ. എന്തായാലും ന്യൂറോ സർജറി കഴിഞ്ഞ ആൾക്കാർ അല്ലെങ്കിൽ സേ RTA വന്ന ആൾക്കാർക്ക് ക്രിബ്രിയം പ്ലേറ്റ് എന്തെങ്കിലും പ്രശ്നം ഉണ്ടെന്ന് പറയാൻ പറ്റും. കുട്ടികൾ ദേ ആർ സസെപ്റ്റബിൾ ബിക്കോസ് ക്രിബ്രിയം പ്ലേറ്റ് ഈസ് നോട്ട് ഫുള്ളി ഡെവലപ്ഡ് ഓർ സോർട്ട് ഓഫ് ഇറ്റ് ഇസ് മോർ പോറസ്. But we are getting a lot of adults also. നമ്മൾ ആദ്യത്തെ ക്ലസ്റ്ററിൽ 10 പേഷ്യൻസിന് we took MRI multiple cuts to see whether the cribrium plate is intact. എല്ലാം ഇൻടാക്ട് ആയിരുന്നു. സോ ബേസിക്കലി ഈ പറയുന്ന ഏത് വാട്ടർ സോഴ്സിൽ നിന്നും വരാം. അതുകൊണ്ടാണ് ഇപ്പൊ കിണർ. ബിക്കോസ് ദിസ് അമീബിക് കെറട്ടൈറ്റിസ് ഒരു 365 കേസസ് 2018 RIO എന്ന് പബ്ലിഷ് ചെയ്തിട്ടുണ്ട് ഡോക്ടർ അന്നാചെറിയൻ. അപ്പൊ അതില് റിസ്ക് ഫാക്ടർ ആയിട്ട് മാഡം പറഞ്ഞിരിക്കുന്ന വെൽ വാട്ടർ, വെൽ യൂസ് ചെയ്യുന്നവർക്കാണ് കൂടുതൽ അമീബിക് കെറട്ടൈറ്റിസ് വരുന്നത്, അക്കാന്തമീബ കെറട്ടൈറ്റിസ് വരുന്നത് മാഡം അന്നേ പറഞ്ഞിട്ടുണ്ട്. കാരണം ഇവരുടെ എല്ലാം വീട്ടിലെ വെൽ വാട്ടർ എടുത്ത് നോക്കിയാൽ മൊത്തം അക്കാന്തമീബ ആയിരുന്നു. വെല്ലെന്ന് പറയുമ്പോൾ 65 ലക്ഷം ആൾക്കാർ വെല്ല യൂസ് ചെയ്യുന്നത്. ഓർ യു ക്യാൻ സേ 60% of Kerala population rely on well water. So well water is a source, overhead tank is a source, all sorts of this thing is a source എന്ന് പറയേണ്ടി വരും. പിന്നെ ഇതിൽ ഈ കുട്ടികൾക്ക് വരുമ്പോഴാണ് കൂടുതൽ പ്രശ്നം വരുന്നത്. അപ്പം ക്ലിയർ ആയിട്ട് പറയുന്നത്, ഇപ്പം നമ്മളിപ്പം ഈ ഗാർഡനിങ്ങിൽ നമ്മൾ ഹോസ് ഉണ്ടല്ലോ, അപ്പോൾ ഹോസ് ഇങ്ങനെ പുറത്തിട്ടിരുന്നാലേ അതിൻ്റെ അകത്ത് വെള്ളം ഉണ്ടെന്ന് വിചാരിക്കുക, കുറച്ച് വെള്ളം. അപ്പം ഈ ഡേ ടൈമിൽ ടെമ്പറേച്ചർ കൂടുമ്പോൾ നെഗ്ലേറിയ ആക്റ്റീവ് ആവും. ഇറ്റ് ഈസ് എ തെർമോഫിലിക് തിങ്. അപ്പം കുട്ടികൾ വെള്ളം ഒഴിക്കുമ്പോൾ സ്പ്രിങ്കിൾ ചെയ്ത് മൂക്കി പോകാതിരിക്കാൻ നോക്കണം എന്നൊക്കെ ക്ലിയർ ആയിട്ട് പറയുന്നുണ്ട്, മീൻസ് ഗൈഡ് ലൈൻസിൻ്റെ അകത്ത് പറയുന്നുണ്ട്. അപ്പോൾ ഈ വാട്ടർ കോണ്ടാക്ട് എന്ന് പറയുന്നത് മീൻസ് ഫോർ എക്സാമ്പിൾ ആലപ്പിയിൽ അറൌണ്ട് 4 months ബാക്ക് വൺ കേസ് വാസ് ഡയഗ്നോസ്ഡ്. അത് ക്ലാസിക് കേസാണ്. അതായത് പോണ്ടി കുളിച്ചു, ഒരാഴ്ച കഴിഞ്ഞപ്പം മെനിഞ്ചോഎൻസെഫലൈറ്റിസ് കോമയിൽ വന്ന് പ്രസന്റ് ചെയ്യുന്നു. പേഷ്യന്റ് മീൻസ് ട്രോഫോസൈറ്റ് കണ്ടു. ദിസ് എ ക്ലാസിക് കേസ്. അതൊന്നും ആർക്കും ഒരു ഡൗട്ടും ഇല്ല. കാരണം പോണ്ട് കുളിച്ചതിന്റെ ഹിസ്റ്ററി ഉണ്ട്. പക്ഷെ അതെല്ലാവർക്കും കിട്ടത്തില്ല എന്നാ പറഞ്ഞത്. ആ ബോയ് 4 മാസം ട്രിവാൻഡ്രം മെഡിക്കൽ കോളേജിൽ കിടന്ന ശേഷമാണ് ഇമ്പ്രൂവ് ചെയ്ത് പോയത്. കാരണം ഫുൾ സബ്ഡ്യൂറൽ എംബൈമ, 2 പ്രാവശ്യം ക്രേനിയക്ടമി ചെയ്യേണ്ടി വന്നു. ആൻഡ് ദെൻ ദ CSF ഗ്രൂ ആസ്പെർഗില്ലസ് ഫ്ലേവേഴ്സ്. അത് അമീബയുടെ കൂടെ കയറുന്നതായിരിക്കാം. അപ്പം ആസ്പെർഗില്ലസിനെ ട്രീറ്റ് ചെയ്യേണ്ടി വന്നു. ആഫ്റ്റർ 4 months he was perfectly fine and he went back home. പക്ഷെ അതൊക്കെ മീൻസ് ഇറ്റ്സ് എ ക്ലാസിക്കൽ കേസ്. ഓക്കെ, അങ്ങനത്തെ കേസ് അല്ല മെജോറിറ്റി സ്റ്റേറ്റ് ഉള്ളത്. എല്ലാം ഈ വെൽ വാട്ടറിൽ നിന്നൊക്കെയാണ് കിട്ടിക്കൊണ്ടിരിക്കുന്നത്. That is why we are chlorinating all the wells. No. Sir, if I conduct effective chlorination, we can reduce cases to a great extent. That is what we hope. We can reduce it to a great extent. പക്ഷേ ഈ പറഞ്ഞ പോലെ നമ്മൾ 0.5 mg/L ആണ് മെയിൻറ്റെയിൻ ചെയ്യാൻ പറയുന്നത്. അത് കഴിഞ്ഞ് എടുത്തു നോക്കേണ്ടി വരും ഇത് അമീബ പോകുന്നുണ്ടോ എന്നുള്ളത്. കാരണം ഈ അമീബ, ഈ 400 ഫ്രീ ലിവിങ് അമീബ ഉണ്ടെന്ന് പറയുന്ന പോലെ തന്നെ അക്കാന്തമീബ തന്നെ അറൌണ്ട് 20 സ്പീഷീസ് ഉണ്ട്. നെഗ്ലേറിയ ഈസ് അറൌണ്ട് 40 സ്പീഷീസ് ഒക്കെ ഉണ്ട്. ഇതിന്റെ ഓരോന്നിന്റെയും ക്ലോറിൻ ടോളറൻസ് ഒക്കെ ഡിഫറെന്റ് ആയിരിക്കും. ആൻഡ് എവറി 3 months യു നീഡ് ടു ഡു ഇറ്റ്. സോ ബേസിക്കലി നമ്മൾ നേരത്തെ പറഞ്ഞ പോലെ തന്നെ വി ആർ ട്രൈങ് ടു ഡു എ ലോട്ട് ഓഫ് തിങ്സ്. അത് നമ്മൾ പിന്നെ ഇതൊക്കെ എടുത്തിട്ട് പിന്നെ നോക്കണം, അമീബ പോയോന്നൊക്കെ നോക്കേണ്ടി വരും. So as of now, chlorination or superchlorination will really work against Acanthamoeba as well as Naegleria and Vermamoeba.
സന്തോഷ് PS അൺമ്യൂട്ട് ചെയ്ത് പറഞ്ഞോളൂ. കൈപ്പൊക്കെയാണ്. അപ്പം വേറെ ചോദ്യങ്ങളൊന്നും ഇല്ലെങ്കിൽ നമുക്ക് ഹീറ്റർ യൂസ് ബാത്തിങ്.
ഹീറ്റർ യൂസ് ആക്ച്വലി നെഗ്ലേറിയനെ സ്റ്റിമുലേറ്റ് ചെയ്തെടുക്കാൻ ചാൻസ് ഉണ്ട് കേട്ടോ. 45 ഡിഗ്രി വരെ നെഗ്ലേറിയ മീൻസ് നല്ലതാണ് നെഗ്ലേറിയക്ക്. അപ്പം ആക്ച്വലി ടെമ്പറേച്ചർ അതിന്റെ മുകളിൽ പോയി കഴിഞ്ഞാൽ ഇറ്റ് ഷുഡ് ബി ഓക്കെ. 45 degrees വരെയാണ് ദിസ് തിങ് നെഗ്ലേറിയ ടോളറേറ്റ് ചെയ്യുന്നത്. ആഫ്റ്റർ ദാറ്റ് ഇറ്റ് വിൽ ബി കിൽഡ് ബൈ ഹീറ്റർ. ഈ ഹീറ്ററിന് ഇതാ പറഞ്ഞു, നമ്മളിപ്പോൾ കൂടുതലും കാണുന്നത് ഒരുപാട് ഈ ബിലോ പോവർട്ടി ലൈൻ അങ്ങനത്തെ ആൾക്കാർ, അവർക്ക് ഹീറ്ററോ ഒന്നും ഇല്ല. അപ്പം ഈ ഹീറ്ററൊക്കെ യൂസ് ചെയ്യുന്ന ആൾക്കാർ സേഫ് ആണെന്നാണ് മനസ്സിലാക്കുന്നത്. ടെമ്പറേച്ചർ ഇമ്പോർട്ടൻ്റ് ആട്ടോ. അതായത് 45 ഡിഗ്രി വരെ നെഗ്ലേറിയയുടെ 30 to 45 ഡിഗ്രി ആണ് നെഗ്ലേറിയയുടെ ടെമ്പറേച്ചർ. അപ്പൊ അതിന്റെ മുകളിലോട്ട് പോകണം. ഹീറ്റർ എന്ന് പറയുമ്പോൾ ഇറ്റ് വിൽ ബി വെരി ഹൈ, അതിനെക്കാട്ടി മുകളിലായിരിക്കും. സോ ഇറ്റ് ഷുഡ് ബി സേഫ്.
വേറെ ചോദ്യങ്ങളൊന്നും ഇല്ലെങ്കിൽ നമുക്ക് അവസാനിപ്പിക്കാം. എൻ്റെ KGMOA ഫാമിലിയുടെ പേരിൽ ഡോക്ടർ അരവിന്ദിനെ നന്ദി അറിയിക്കുകയാണ്. വളരെ ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള ഒരു സെഷൻ ആയിരുന്നു. കാര്യം നമുക്ക് പലർക്കും ഒരു ഐഡിയ ഇല്ലാത്ത, അപ്പോൾ ഈ പറഞ്ഞ പോലെ 75% AES ഡയഗ്നോസ്ഡ് അല്ല. അപ്പോൾ ഇതിൽ കുറച്ച് അമീബ ഉണ്ട്. ഇനിയും പുതിയ പുതിയ സാധനങ്ങളൊക്കെ നമുക്ക് കണ്ടുപിടിക്കുമെന്ന് പ്രതീക്ഷിക്കാം. ഓക്കെ, താങ്ക് യു.
Thank you very much.
Good night.